Okay, this is your pre-lecture video for Chapter 6 for Transitions and the Claywell textbook. Chapter 6 is about providing patient-centered care through the nursing process. So let's talk a little bit about the nursing process. In the early 2000s, we were still talking about API and transitioning to ADPI whenever I went to nursing school. From assessment, plan, implement, evaluate, transitioning to assess, diagnose, plan, implement, evaluate. And now we're doing assess, diagnose, outcome identification, plan, implement, and evaluate. So the nursing process is getting more refined over time. It's not that we did less years ago, it's that we are articulating what it is that we do. So, how did it all get started? Well, Lydia Hall is considered to have started the nursing process by formulating a standard way of caring for patients with observation, administration of care, and validation. Then Ida Jean Orlando came along, and she was the first to call it the nursing process and named the steps assessment, planning, and evaluation. In the late 60s, somebody named Ura and somebody named Walsh developed four-step nursing process: assessment, planning, implementation, and evaluation. Previously, it was implicit or understood that you had to carry out what you had planned, but it is so necessary to put into words what we do in order to help us think about what we do and to legitimize what we do to collaborating professionals. In the 1970s, not only was diagnosis added, but NANDA diagnoses came about during this time. You have an entire nursing diagnosis textbook that fleshes out actual and potential diagnoses, along with how each diagnosis ties into the nursing process. Well, it started rudimentary and it has become more refined over time. In the 1990s, the ANA, or the American Nurses Association, introduced outcome identification. So, looking at this information, it makes me think about how often I wonder what organizations like the ANA do for me personally or for the profession of nursing. Sometimes I see them mentioned in pamphlets or on the internet. And I wonder what they do. But I can see very plainly when I look at this information on this slide how they helped identify what was actually happening in practice. And then that helps to guide future nurses in skills that they're going to need when they enter the profession and take good care of their patients. Today, we have the 5 steps of the nursing process, and outcome identification and planning are sort of combined into one step. In nursing school, we aim to improve your critical thinking skills, and not just because we love education and want to make things really hard on you, but we want you to become an excellent critical thinker because it results in good clinical judgment. In practice, we are taking care of very complex patients, and they get more complex every year. As medical care improves and we keep patients alive longer with more diseases, then they do come to us for care. And so they might have many processes going on at once. And it's the RN's job to kind of choose the course of a patient's hospital stay. RNs create a plan of care when a patient gets admitted, and that plan of care should take the individual patient into account. We should be talking with our patients and collaborating with them when we make decisions about goals for the day and things that are going to be done to help them meet their goals. So I want you to think about a time when you've been told what to do. Sometimes it feels like the other person is being condescending, and often adults will feel disrespected when they're told what to do. But if you have a relationship with another adult and you offer to help them identify and meet their own goals, you're going to work well as a team. So we're not telling our patients what to do, we're working with them. It really is an art and a science to flex your critical thinking skills and help solve patient problems. So assessment is the first step, but it certainly happens continuously throughout a nurse's encounter with a patient. Remember that objective data are facts that can be measured and verified, whereas subjective data is information that is experienced and can be described only by the patient, and it can't be verified or quantified easily. Examples of objective data would be things like vital signs, size and location of a wound, and the color of drainage. But subjective data would include things like your patient's experience of pain, fear, anxiety, and even nausea. So we collect data on our patients and we recognize that the patients do not exist in a vacuum. Think about all of your nursing theorists. So many of them mentioned that the patient exists in an environment with a family, a community, a culture, and they are not existing just in a vacuum. So we need to include gathering data on family and community if we're going to treat the patient well. We look at 5 realms: the physiological, psychological, social, cultural, and spiritual. When I think about the difference between doctors and nurses, I think about how doctors treat disease and nurses treat patients. A doctor may consider certain parts of these realms, but the nurse must consider all 5. And we do. We do it on a daily basis to provide care for our patients around the clock. Let's not forget that our assessments should be systematic and organized, and we've got to be competent in interpreting lab data as part of our assessment. Last of all, I want to mention that we have to be able to accurately communicate what we assess, whether by documenting our assessment in the electronic health record, but also being able to pass that data on to collaborating healthcare professionals. In order to gather, in order to gather the information we need, we use 3 main data collection methods. So we interview our patients by asking them questions. We observe them, not just in a moment, but by watching their behaviors throughout the day over the course of time. And then also we use our physical assessment where we inspect with our eyes, we auscultate with our ears, we palpate with our hands, and sometimes we even use percussion. As a registered nurse, you'll be expected to do more detailed assessments and interpret assessment data for more complex patients than you have in the past. Marjorie Gordon developed 11 categories of functional health patterns that make a systematic and standardized approach to health assessment possible. And then we have Virginia Henderson, who was mentioned in the previous chapter, who identified 14 needs of the individual and provided a holistic approach that includes the spiritual needs of the individual as well. So here are Marjorie Gordon's 11 patterns and Virginia Henderson's 14 needs listed out. Think about the breadth of information that Gordon and Henderson want you to gather. When you walk into a patient's room, do you have to ask a list of detailed questions to learn this type of information from a patient? Can some of this data be gathered through conversation and showing interest in your patient and who they are? Do you need to gather each type of information to the same depth for each patient? I'll answer that last one. No, you don't. Think about the patient that you're assessing that is struggling with nausea and vomiting. You're going to ask them more detailed questions about what they take in and what they eliminate than you would ask the patient that you're assessing who is having a stroke, for instance. Assessment of a stroke patient will absolutely include what they're eating and what they're eliminating, but the focus of your assessment is going to provide greater depth into their neurological status than it would their GI status. Remember also that you do not work in a vacuum. You work in context of a healthcare team and collaborating professionals. Not only do you need to keep your data clear and organized for your own thoughts, but you'll need to be able to communicate your data clearly, both orally and in written or computerized documentation. You'll also hone your ability to compare or validate assessment data. You'll get better at recognizing when the patient is telling you something that doesn't really make sense with what you're observing for yourself. Let's do a practice question about the nursing process. A nurse collected the following data. Which data are subjective? Number 1, the patient breathes 14 times a minute. Number 2, the patient has a dime-sized wound on the left leg. Number 3, the patient's sputum is rust-colored. And number 4, the patient is nauseated. Remember that subjective data are something that the patient experiences that we can't verify objectively. And so the correct answer for this is number 4. Everything else we can go back and we can verify objectively and provide proof to others that that's the situation. We can measure it, essentially. Next, we've got the nursing diagnosis. So a nursing diagnosis is determined when our patient reveals alterations from normal. We cluster those alterations and we interpret what they mean. So as a registered nurse, you're going to have to do this. Every single diagnosis will have identifying criteria. You can read about those in your nursing diagnosis textbook. The identifying criteria are data used to justify choosing that diagnosis. And this is the evidence that we provide for choosing that diagnosis. Now, some complex patients will have many problems, and you will have to use critical thinking to identify their priority and the priority nursing diagnosis that accompanies that. Nursing diagnoses may be actual, potential, or there might even be some wellness diagnoses. Your nursing diagnosis textbook can help you decide which to select. Please bring it to clinical every time. We use the PES format to communicate our nursing diagnoses, and you may not have heard of PES before, but it just means problem, etiology, signs, and symptoms. So this you probably have heard before, this format. Problem related to etiology as evidenced by signs and symptoms. Now, many times a patient's problem will be considered collaborative. Yes, a collaborative problem, meaning that the interventions for that problem are collaborative, requiring multiple members of the healthcare team. The nurse, however, remains the primary person responsible to continue assessing the patient, detecting changes, and watching for any deteriorations or complications that may arise. The nurse is the one that must communicate with the team and advocate for the patient, and also communicate with the patient. As an RN student, you're going to be asked to really refine your nursing care plans. And a refined nursing care plan doesn't mean that it's 27 pages long. A refined nursing care plan means that you accurately focus on the important information. You're going to have to become an expert at selecting priority nursing diagnoses. And if you're struggling with doing that, please take extra time to practice that sooner rather than later. Talk with your clinical instructor when you're in clinical and ask for their opinion. Come up with your own idea first and ask for your clinical instructor's opinion. Tell them which nursing diagnosis you would choose as priority and give them the evidence for why. It's going to make your clinical assignments much easier and you're going to feel a whole lot more successful. Ackley and Ladwig created 5 steps to selecting a nursing diagnosis. First, you highlight or underline the relevant symptoms. Then you make a short list of the symptoms and cluster similar ones. Remember, complex patients might have multiple symptoms. If you take symptoms from this medical diagnosis and this medical diagnosis and you try to put them together, you might not be able to gain any traction on figuring out what your patient's problem actually is. So you've got to cluster those symptoms into similar ones. Then you're going to select a nursing diagnosis label that fits with the appropriate related factors and defining characteristics. As you progress through your education and become an RN, you're going to take care of more complex patients, like I've mentioned multiple times. You're going to take care of patients that have many problems. You've got to prioritize them. You're going to notice a whole lot of standardized questions like HESI and NCLEX that revolve around prioritizing problems and interventions, and even prioritizing patients themselves. When you prioritize problems, you will choose the most critical problem to receive the highest priority. And the problem that's going to kill the patient the fastest is going to be the highest priority. It sounds simple when I say that, but sometimes it can be difficult. You can think about Maslow's hierarchy of needs. Physical needs are at the base of the pyramid, and they're required to be met first. Safety is often going to trump physical needs, though. Outcome identification feels more intuitive to me, but that may not be the case for everyone. So typically, when we make goals, we make them for our shift. On your care plans, unless your clinical instructor tells you to do otherwise, when you make goals or you do your outcome identification portion, please pick goals that can be met during your shift. Oftentimes for nursing assessments, that's going to be the default. In reality, when you're the RN creating a care plan, you're going to have to choose immediate, intermediate, and long-term goals with collaboration of the patient and family. Also, our goals have to be SMART goals. So SMART is actually an acronym for specific, measurable, attainable, relevant, and time-based. As a clinical instructor, I choose the time frame to be during my shift. So that handles the time-based part. Specific means that goals are clear and narrowed down. You shouldn't have 10 goals wrapped into one. You should have, for one goal, it should be one specific, clear goal. They're measurable, and you have to you have to define how you're going to measure each outcome or goal. They have to be attainable. Remember your time frame. So think about what goals make sense in your time frame. For me, like I mentioned, I choose shift. So think about what can be accomplished during my shift. And then relevant. Verify that your goals are relevant. Remember too that you can use that acronym for your own personal goals as well. Make your own personal life goals SMART goals. Okay, every diagnosis has its own goals or expected outcomes. So when you're making your care plans, the same problems and criteria that you that you chose as evidence for choosing that diagnosis should be addressed in your goals. Those were the problems, so that's what you're trying to fix, right? So your outcomes, they should be measurable. You should communicate all of the information in your written care plans. You don't need to add in extra words or fancy words, but it does need to be on paper. The outcome identified on your screen right now is a nice, complete goal. It's kind of cut off with my picture, but it says the patient's pain will decrease to 2 or less on a 0 to 10 pain scale by the end of my shift. And that's perfect. You see, it's not 10 lines long, but it is detailed. And I say exactly what I'm going to measure, how I'm going to measure it, what I want it to be, and the time frame. And also, it's attainable. Saying somebody's pain is going to be 0 when they're experiencing a health issue, that may not be attainable, but 2 or less, that might be very attainable for most patients. The Center for Nursing Classification and Clinical Effectiveness at the College of Nursing at the University of Iowa developed the NOCCS, the Nursing Outcomes Classification. So they developed 490 NOC outcomes, and you can see these in your care plan textbook. They are standardized. And what that means is that nurses in all settings and across several countries can are going to define them the same way. That's the essence of standardization. So these outcomes provide measures for comprehensive outcomes, which means that if you're using your care plan textbook, you're going to be more successful. A lot of the thinking is going to be done for you. You just have to make sure that your selected outcomes are applicable to your patient. You don't have to design things from scratch. What you want to do is look at the standardized information that's provided, pick ones that apply to your patient and that apply to your patient's problems. Remember the evidence that you chose for why you chose that nursing diagnosis. And you want to pick outcomes that address those problems. Next is planning. So remember back at the beginning of the lecture, I mentioned that planning and outcome identification are considered one step. Well, here's why. Planning actually includes the outcome identification. It's part of the planning. You gotta plan your goals and then plan your interventions. So that is why it's considered one step. And just like we talked about with outcome identification, in addition to standardized outcomes called NOCCS, there's also standardized interventions called NICS. So when you're planning care, you're going to plan your NOCCS and your NICS. Nursing care provided to patients should have some level of uniformity, regardless of your location, because we have scientific data that show which interventions are effective, and we should be providing evidence-based care, which we'll talk about another day. Nurses provide care that's evidence-based, so use your textbook and find the standardized interventions for the nursing diagnosis you've selected. Ensure that you choose interventions that are specific to your patient. So as we look at this information on implementation, this is where we carry out what we planned. And I see that it says the RN serves as the gatekeeper for the patient. We make sure that our planned interventions take place. And sometimes we can delegate those interventions, and sometimes we have to carry out the interventions ourselves based on the type of intervention or the patient. But RNs are ultimately responsible for evaluating the patient after interventions are done and updating the plan of care. We document and we provide teaching to the patient. RNs retain full accountability that the plan of care is carried out in a time-sensitive and effective manner. If you have planned an intervention to help a patient and it requires collaboration from the healthcare team, and somebody is unwilling or unable to carry out the intervention, the RN should consider whether it's appropriate for them to be able to carry out the intervention. The final step in the nursing process is evaluation. So the nurse is checking to see whether or not their interventions have been effective. And part of that evaluation is looking at whether or not the outcomes were met. Remember the outcomes that we decided on? Now we've got to decide whether or not they were met. And as a clinical instructor, I prefer short evaluations. I want to know explicitly whether or not an outcome was met. Just like I mentioned during the assessment piece, assessment does occur throughout the nursing process. Assessment never stops. You don't have any patient interaction where you should be completely blind to what's happening with your patient. I even say When I go into a patient room for any reason whatsoever, I usually just peek at their IV to see how it's doing and see if it's looking red or looking like it's going to start leaking soon. Um, and I always notice their mood or their demeanor, and I try to assess further as needed. So, this whole nursing process is not strictly cyclical, like in a circle, like a circle shaped cycle. That's not what's happening. It's a dynamic process, dynamic, and it requires the nurse to use critical thinking skills to determine when to switch from one part of the nursing process to another one. The plan of care may ultimately need to be changed based on the patient's needs and problems. The RN should be recognizing that and communicating it to the other members of the healthcare team. Some problems that patients have are going to get worse, and sometimes brand new problems present themselves during the patient's stay. And the RN has to adjust and provide the best possible care for the patient every single shift. So instead of just a circle showing how we go from assessment, diagnosis, outcome identification, planning, intervention, and evaluation, I like something that looks like this. These arrows, point in different directions and kind of show that it's really a dynamic process. This is a more basic image that you have seen, I'm sure, at some point where it's just a circle. And so you can compare the two images. And when you think about what you do at your work as an LVN, do you do just like a very simple stepwise process, or does work look a little bit more like this one, where you're kind of bouncing back and forth and having to adjust based on your patient? So we finished talking about the nursing process, and now I want to talk a little bit about concept mapping. A lot of times we can concept map before we write out a traditional care plan, and sometimes concept mapping can be used to show your thinking. I do like that it's a great visual. At any rate, for this course, you'll provide whatever your instructor requires paperwork wise. You're probably familiar with the traditional nursing care plan, but like I mentioned, concept maps are a nice visual representation of a care plan. And if you're a visual learner, remember we talked about learning styles. If you're a visual learner or you enjoy kinesthetic learning, or what is it, phase 2 or 3 of Kolb's um, learning theory that says that some people are data organizers. Um, some people might really enjoy a concept map. It does help to show relationships between the data represented as opposed to just, you know, lots of words on a piece of paper. And it does help give additional meaning to the data. So let's take a look. This is a very basic concept map, and it probably shouldn't be used as an example of something you're going to turn in for any assignments necessarily, but it is a great way to get you to start thinking about how a concept map might look. And maybe we'll practice one of these in class. So this shows the patient's problem of dyspnea. The patient is an elderly man, and the patient's represented in the middle of this concept map. The assessment data is shown in all the other circles around the outside of the patient, and you can see that subjective and objective data is documented on this concept map. So how do you develop a concept map? Well, there are different ways, but I'm going to talk about what your book lists as 5 steps for how to develop one. Sometimes these steps are going to change based on the concept map you're completing. For instance, uh, on these 5 steps, step 1 is to fill in the middle circle with a medical diagnosis. But you'll notice on the previous concept map, what was in the middle? The patient. The patient was in the middle. So your book says to put the medical diagnosis in the middle. And then you look up relevant nursing diagnoses and place one per circle around the diagram. And then you add patient data to each circle where it makes sense to go. Then you number your circles in order of priority. And you're going to create a table that lists interventions for each of those nursing diagnoses. And step 5, the last step, is to write the patient responses to the interventions and your evaluation data or progress towards the goals. This particular concept map shows greater detail than the one that your book has, and this is more like the level of detail and quantity of information that maybe you'll be expected to turn in. You'll receive clear details about what your clinical instructor wants you to turn in regards to a concept map. But you're going to notice that this concept map has the medical diagnosis in the center of it, and it has information about the patient. Let's look at another one. Boom. You can see that colors have a greater meaning in this concept map, and it is a lot more detailed. Um, so you can see this was a student project created at another school. And in the middle, it has the patient, the 4-year-old female. And then each of the assessment data is green, and then in pink, you have nursing diagnoses, and then in blue, you have interventions. Okay, so I like that one because the color really is pretty. I would hate to have to make one like this just personally, but I do love looking at one like this. Visually, it is very appealing for me, and it does help me understand this patient when I look at this one. Here's another style, and this one's called a spider concept map, where there's like a list of things at the top, and they all point to hyperthermia, or a nursing, or excuse me, that's a medical diagnosis, and then it has interventions or whatever. But you just notice it all points to one, and then it spreads back out again. So this is just to show you there's different types of concept maps, and again, different levels of detail. So let's look at a quick question. These questions are basic and simple, but it does get our brains thinking a little bit. So it says a nurse is developing an individual care plan for the patient. Which step of the nursing process is the nurse using? So this is a positive question, and they're looking for us to determine at which step of the nursing process is the nurse developing a plan. So I'm going to say answer number 1, planning, for this one. And if you chose number 1 as well, good job. You should congratulate yourself for getting that correct. All right. So that's that. Let me just put this over here. If you have any questions about this content, please feel free to contact me. Also, I do want you to go ahead and read your lecture chapter. Okay? Thanks so much, and have a good day. Bye.